this? We can treat it with by reducing it, which is the realignment of the bone ends. We have close reduction, where the physician manipulates it into the correct position, and open reduction, which is when we use surgical pins. Immobilization is done to allow the bones to remodel or grow back into their normal position, and traction can be helpful in using that. So how this repairs depends on how much time it takes, depends on the severity of the break, which bone is broken, and the age of the patient. I would add in nutrition as well, and of course their treatment plan. So here's a external fixation device. This could be used as a temporary solution with someone having a break before they could have a surgical intervention on a more sophisticated level. So it's called external because the hardware is on the outside. Okay, this was the more typical type of treatment in the past, but now we more often see internal fixation, where the hardware is on the inside. So here's the break, and then it gets realigned, and then the hardware can be used to realign too mechanically, right? You can place that hardware in and then tighten it down, and that will draw it in to alignment. Okay, so on the cellular level, what's happening? Well, we have fracture repair in 4 stages: the hematoma formation, fibrocartilaginous callus formation, the bony callus formation, and then eventually the remodeling. So fracture repair is triggered by the bone death. The death of the cells is what sends the message that we need to have all the other cells come in for fracture repair. Okay. Likewise, the damage to the periosteal, the periosteum surrounding, and the compact bone blood vessels. The blood vessels, when they become leaky, right, they transmit that chemical that will initiate a fracture repair. So here we see a great illustration of a blood clot, we could call it, a hematoma being formed here due to the blood vessels being damaged, so these leak out. This is when we have a swollen, painful, and inflamed area around that bone, right, because of the blood. And the next stage, the capillaries are starting to grow into the hematoma. So you had leaky blood, but now you have capillaries, which are the vessels, right, the tiny vessels growing into that area. At the same time, fibroblasts are secreting collagen, right? So that's creating the framework for which the bone can then be deposited around, the fascio, and it's giving it strength and form. The phagocytic cells, right? Those cells are the ones that are clearing away the debris, the excess damaged material that doesn't need to be there anymore. And then we have these cells that are going to begin reconstruction of the bone. So they're going to create the cartilage matrix, and they're going to begin to form the spongy bone within the matrix as well. The mass of repair tissue here, that is, it's no longer just that blood clot, right? It's the collagen fibers, it's these other cells secreting their goodness into the matrix as well to repair. That's what this is here, and that's the fibrocartilaginous callus. And right, the name is right there because you have the fibers and the cartilage cells within there secreting. So the next stage is that goes from that kind of softer form to a harder form, right? And that's when we get the bony hard callus conversion. So it's spongy bone to start, so it's not compact yet, right? That'll come later. The bony callus formation, it continues for about 2 months. So this begins, this is just what I said. So the bone remodeling begins then within that week, and then it continues for 2 months. So that just says 2 months there. Excessive material and diaphysis. So here's our diaphysis, right? and within the medullary cavity needs to be removed. So that'll be broken down and reabsorbed. The compact bone will be laid down on top to make that nice hard spot in our hard part of the bone. And then the final structure will resemble the original structure. So this is the remodeling phase. Here it is in a one slide now. So hematoma, the cells doing their work of tissue repair, and then the bone being laid down within that framework. And here we go, our fracture is remodeled, and it's quite phenomenal that our body is able to do that. Another image of this, if you want to look at it with me or without me, this is just, it's another older version of the same thing. So this is just saying what I said before. So I'm going to plug away right into skeletal pathology. So we need proper nutrition, right? And vitamins are going to directly affect the bone. So there's certain vitamins that with deficiency, not enough of them, we're going to have inadequate balance between bone deposition and bone resorption. So we have deficiencies related to D, C, and A. I'm not going to present A, but I'll present D and C because they're on the exam. So vitamin D allows for proper absorption of calcium. Vitamin D is technically a hormone. We call it vitamin D, but having adequate vitamin D levels in our body, right, allows for calcium to be used, and phosphorus as well. But without it, it doesn't resorb properly, and we're not able to utilize it. So we have to have both D and the calcium itself, right, and phosphorus present in order for proper bone health. Vitamin D also affects the renal resorption of calcium, and when we have a deficiency, we have rickets or osteomalacia. So I'll talk about osteomalacia first. Osteomalacia is it's going to be a similar pathology to rickets, but it's in adults. Okay, so the bones are poorly mineralized. The calcium salts aren't adequately deposited, and you have soft, weak bones that are painful when you're walking or weight bearing. Rickets, osteomalacia of children, because it's during bone growth development, you have a weakness or a bending in the bone, right? And that leads to bow-leggedness. So it presents differently in a child because it's during their normal bone growth. With an adult, it presents differently because the bones have already taken their long bone form right by age 25. So specifically rickets, right? Same thing, vitamin D deficiency. It could also be, because they go hand in hand, related to dietary calcium. So let's look at this a little further. The epiphyseal plates are not going to calcify, and because we don't have the adequate calcium there, and you're going to, because that's not happening, it's not calcifying, you're going to end up with thicker cartilage at the epiphyseal plate. So still mitosis continues, but we don't get the deposition of the bone. The bones therefore are soft, and that's again what will lead to this bending. We also see abnormal teeth development, and then like I said, you might not even notice it in the infant who is deficient in vitamin D, but then when the child begins walking, that's when the bowing of the legs presents itself. Black children, let's black be synonymous with glory. Okay, so genetically, there is a genetic link between the amount of melatonin in the body and the amount of vitamin D absorption. Okay, because we know, right, the UV light isn't penetrating as much, and so neither is the vitamin D coming from there. So in that case, we have an at-risk population based on melanin concentration. So to continue this, if you have high melanin concentration and live in an urban area where you're not exposed to sunlight due to high buildings, or maybe it's unsafe to go outside, right? That will affect your ability to acquire vitamin D, and right, lead to a deficiency. So that means that people or children in that place are more at risk. Here is a little bit of that bow-leggedness. Genuvarum is what it's called for the technical term. And then in the adult here, what we see is that there's variable bone pain, and there might be a mild bowing of the limbs, but it's not going to be as severe as what you're seeing in children. So the weight of the adult body causes a little bit of bowing. It can cause compression of the backbone and flattening of the hips. This will overall lead to a little bit of a decrease in overall height. So one thing that might come up is, you're 5'4", and then the next thing you know, you're 5'2¼ something like this, and it has to do with the onset of this disease. So this could be secondary to malabsorption. So not only do we need vitamin D for calcium absorption, but if you have a malabsorption disease and you can't absorb the fat-soluble vitamin D, then you also lead to this. So that would be like a backup cause, secondary cause. Dietary deficiency, of course, in calcium or with lack of exposure to the sun, and then multiple pregnancies. So every time a woman becomes pregnant, she builds the skeleton of her child with her own skeleton, right? So the resources have to come from somewhere. So that over time will lead to weakened bones in itself. So as a woman who has 8 children is more at risk for osteomalacia, for example, than a woman who has 2 children or no children. Lactation as well is pulling from the body the nutrients as well, and that will also where it will cause a depletion on some level within the skeleton. Okay. What else is happening here? Vitamin C deficiency. All right. Well, we need it for collagen, and the matrix depends on collagen. So if the growth can be inhibited due to lack of that matrix, and therefore lack of vitamin C is important. If you don't have it, you might have thin bones as they grow. And if it's in an adult, and then you experience a fracture with lack of vitamin C, you're going to have delayed healing. So a fracture is going to take longer to heal. Love this. I'm so excited about it. Okay, so we were talking about lack of vitamin C is going to be without collagen. We're going to get this brittle bone, and then if we didn't have the vitamin D, the deposition of calcium, phosphorus coming down into, we would have a bendy bone. So here's our normal bone. Here's without collagen, making it brittle. Here's without mineral, making it bendy. And I'm going to have to end here.